Hi everyone, my name is Serena Perkins, and I'm going to be presenting to you today my pathophysiology case study. So I had a patient named Mr. Jones who was admitted to the emergency department with complaints of increased anxiety, chest discomfort, shortness of breath. He was experiencing dizziness with exertion. He had very pale skin and some diaphoresis. The physician came and assessed him and noted that with the chest pain that he was complaining about, that it was actually worse on inspiration and expiration. So they felt like that was more of a pleuritic chest pain. The patient was afebrile. He was experiencing an increase in heart rate, increase in respiratory rate, and he was hypoxic. An EKG was completed. They did note a T-wave inversion in the anterior leads. And so they really thought that his problems could be related to a cardiac source. But the pleuritic chest pain kind of made them feel like they need to do some further investigation. So they drew a CBC, they drew a BMP, and those are kind of standard labs for any individual who is admitted to the emergency department. One of the other things that they wanted to look for, because COVID is a thing now, is COVID-19. So the physician ordered a chest x-ray. The chest x-ray, what they would have been looking for in an individual who had COVID-19 would be those ground glass opacities. His chest x-ray did not show ground glass opacities, but it did show some atelectasis and some pneumonia. So the doctor then ordered a CT scan, and it was on the CT scan that they did find a pulmonary embolism. The physician, because of the T-wave inversion on the EKG, the physician did decide to order serial cardiac enzymes, and that included the CKMB, the D-dimer, and the troponin. They also decided to take the patient for emergency to the cath lab for an emergency angiogram and an aortogram. When they did that, they did do a thrombolysis as much as they could, and then they inserted a femoral, an arterial line. Excuse me. They entered a femoral arterial line, and they put it's a therapy called ECOS. And what that does is they thread a catheter into the artery up near the area of the embolism, and it provides a gentle vibration, which helps to break apart that clot. Simultaneously through those catheters, or well, this patient actually had 3 arterial catheters, and then through the second and the third catheter, he had heparin and TPA infusing. And this was also to help break down that clot. Another thing that they did put in was a Swan's catheter, and that would be so that we could monitor the pulmonary artery pressure of this patient. Now, the patient's past medical history included diabetes mellitus. He did have dyslipidemia. He did have hypertension, emphysema, and COPD. So what a pulmonary embolism is, it's basically a blood clot. It's a blood clot that has traveled to the lungs. I will tell you that blood clots typically originate in the large veins of the legs and travel upwards. Roughly about 900,000 people in the United States are diagnosed with pulmonary embolisms annually, and that's according to the Centers for Disease Control and Prevention. And about 25% of those individuals experience sudden death. Now, there are certain risk factors for a pulmonary embolism. Women who take estrogen and that's because it increases our clotting factors. People who experience abnormal heart rhythms, such as a flutter or atrial fibrillation, that's because you're going to have stasis of that blood, which means that blood is not moving, it's not circulating, and when it sits there, it clots. It tends to clot. Um, Other people at risk, individuals with cancer. What happens is in response to kind of these foreign tissues, our bodies create an immune response. And that a part of that immune response is to increase clotting. Some other factors include blood clotting disorders, people who have had surgery because they're at risk for fat embolisms, individuals with poor venous return, um, and individuals who are pregnant. And again, that's going to be because of that the poor circulation, the poor venous return in those patients. So we discussed earlier that the signs and symptoms of a pulmonary embolism and how they can kind of mimic signs and symptoms that have a cardiac origin. Again, the patient may complain of chest pain. In this instance, the patient had a pleuritic chest pain. Usually in individuals who are experiencing like a myocardial infarction, they may complain of a substernal crushing chest pain. It may radiate to the shoulder. It may radiate to the jaw. They may complain of indigestion. And that's kind of more one of those atypical signs of a myocardial infarction. But it's important to note that individuals with PE, when you have a blockage and you have that lack of oxygenated blood getting to the surrounding tissues, you can experience cardiac damage in those instances too. This is why it will lead to an increase in the troponin, the CKMB, and the D dimer. So, okay, so the D dimer, what that exam is, we use this to help determine if a clot might be present. So when you have a clot, our body will try to break down the clot. Like our defense mechanisms kick in and our bodies try to fight it and break it down. What happens is we have these proteins that are then released into the blood and they're called D dimers. And so that's why when the D dimer is elevated, we consider that indicative of a possible blood clot. Again, we had the troponin, the CKMB, that was also elevated. And those labs are going to be elevated in the event that the patient experiences damage to the cardiac muscle. Another test that was performed was a BMP. And those are proteins made by the ventricles of the heart. So when the ventricles are stressed or they're dilated, which with a pulmonary embolism, you will experience some right ventricular dilation. You will release the basic natriuretic peptide. It's a protein. And so this can tell us if the patient is experiencing heart failure. So again, anytime there's any strain on the heart, the blood vessels dilate, the BMPs are elevated. So just to review, this patient presented with a T-wave inversion on the EKG. That's indicative of cardiac ischemia. The doctor decided to order a echocardiogram. This is an ultrasound of the heart. This would allow us to see the blood flow through the heart. It'll allow us to see the dilation in the right ventricle. And of course, any changes of blood flow through the pulmonary artery. So we're going to use this as a tool to help diagnose the pulmonary embolism. So we can do a chest x-ray. We did the CT scan, which is like probably the best test you can do. to see the pulmonary embolism, but you can also do a VQ scan. And what that's going to allow us to see is the perfusion when the patient ventilates, how the air perfuses through the lungs. We did not do this test for this patient, but it is something that the physicians can order. So with these patients require increased monitoring because there is a chance that they can suddenly, rapidly deteriorate in cardiac arrest. This patient had a submassive PE, and I want to break that down because you do have massive and you have submassive. With a submassive PE, basically what we're saying is that this patient is hemodynamically stable. It changes to a massive PE when the patient starts to experience a decrease in blood pressure, an increase in heart rate, hypoxia that requires increased therapies such as BiPAP or even mechanical, invasive mechanical ventilation. So this patient at the time that he was admitted to the ICU was stable. He was admitted to the ICU primarily because we had the ECOS catheter in place with the TPA and the heparin infusing. This patient began to concern me because his blood pressure started to decrease. And it started to decrease to the 90s systolically. We do more often monitor the mean arterial pressure in our patients. We like that to be about 65, and that indicates that the kidneys are perfusion. However, you have to look at the bigger picture. If this patient was previously in the 140s and suddenly they're in the 90s and they have an increased heart rate, that's a problem. That's a change in status. And so I was worried that he was starting to become hemodynamically compromised. And at which point, if that were to happen, this is now a massive PE. So this patient was extremely confused. He was thrashing all around the bed. He had 3 arterial sheaths. He had 1 Swan's catheter and was really at risk for injuring himself. So in order to keep this patient safe, we had to sedate this patient. He did require increased assistance with his oxygen, so we switched him from the high flow nasal cannula to a continuous BiPAP. Once he was sedated, he was able to relax, and we were really able to do good therapy with this patient. So I will say that this patient, he ended up transitioning from the arterial heparin and TPA. It took about 2 days to a IV heparin infusion. With that, any patients diagnosed with PE are most likely going to have to be on long-term anticoagulants. And so what we had to do was bridge this patient from intravenous heparin to warfarin. That required that we drew his PTINR to ensure that the Coumadin levels were therapeutic in his blood. So some of the teaching points for individuals who are diagnosed with a PE and are going to be expected to take anticoagulants. First, what I want to let my patients know is that if you start to feel any shortness of breath, new onset difficulty breathing, like this patient does have COPD, and I'm sure he's used to living with a certain amount of shortness of breath. But if it were to worsen more than normal, or patients, you guys know your bodies. You guys know when something feels off. I would stress to my patient that I don't want you to wait. I don't want you to try to decide, if this is normal or abnormal. Schedule an appointment an appointment with your physician, and if it's that bad, I would advise the patient to just come back to the emergency department. Another thing that they may want to look out for, any swelling, abnormal coloring in the lower extremities that might indicate a deep vein thrombosis. Because again, individuals who have developed a PE are more prone to developing pulmonary embolisms in the future, or DVTs in general. So we want to make sure that if we're experiencing a new onset of swelling in our legs, redness, warmth, pain in the calves, that we notify our physicians immediately or come to the nearest emergency department. The second thing is to take our medicines as prescribed. Again, we're going to most likely be on some type of anticoagulant. In his case, he's also going to be on probably a statin because he was hyperlipidemic. So we want to make sure we're taking those medications consistently, daily, that we're getting our follow-up labs at our doctor's offices to make sure that those medications are therapeutic. And then another thing that we're going to want to stress is that we want to make sure that we do activities that are going to decrease our risk for trauma and bleeding. For instance, for men, for women alike, we want to encourage them to use electric razors. We want to encourage them to use soft bristled toothbrushes. We want to encourage them to avoid contact sports, maybe some nice cardiovascular for exercise. And another big thing is diet. There are some medications that interact with Coumadin, so we want to be sure to explain to them that, hey, you need to let your physician know if you plan on starting any medications. That includes medications that are not prescribed by the physician. Herbal remedies, those can definitely affect our Coumadin levels. Diet, green leafy vegetables. Now, I'm not going to say you can never eat green leafy vegetables, but you can absolutely not eat green leafy vegetables every day. And the reason why is because those green leafy vegetables contain vitamin K, and vitamin K is going to counteract the cumin, the warfarin in your body, and it's going to increase your risk for clotting because it's going to basically inactivate the Coumadin. So those are some other things that I would want to stress to my patient. So just to kind of get back to the patient, his blood pressure did decrease. That was a concern. Again, he did not deteriorate. So we were definitely happy about that. In fact, again, he was able within a few days to have those sheaths removed and be sent to our step down or intermediate care unit. And then subsequently he was discharged home. So again, I think one of the important things is patient and family teaching for these patients to make sure that we don't have a readmission for the same issue. I do believe that that concludes my my presentation. I thank you for listening, and you guys have a good day. Thank you.